Our speakers, Kernan and Williams, have examined how the pandemic has produced market failure in the private health services, particularly in the provision of tertiary care. Now I open the floor to Kernan and Williams.
Great, so thank you so much for that introduction. The way that Owain and I have decided to split this up, that is, I'll start with a bit more of a description of what we found in terms of the types of challenges that we've seen health systems in many low and middle income countries facing, particular in how the private sector has been both affected and is reacting in the context of the pandemic. And then I'm going to hand it over to Owain, who's going to give you a little bit more of the background and context as to why we think these things have manifested themselves. And then also to start a conversation that we hope to have with the audience as much as possible with the other half of this talk about what are some of the possibilities to get us out of this, and how do we think about preparing for the next pandemic so that we don't see these same things replicating over again. So I'm going to try to share my screen. This always goes either this works or this doesn't. So please, someone yell at me if you can't see my screen in about 1 second. Anyways, otherwise, I'm hoping you can see my screen and I'll begin. But anyways, yeah. So this what we're presenting today is some work that was just published in Global Public Health, and so it's an incredible opportunity to start presenting work that was only just hot off the press just a couple of weeks ago. And then also Owain will be presenting some additional work that he has in a companion piece that's been published in the Journal of Development. So hoping, yes, okay. So just to as sort of background and context to this, I think anyone who's showing up to this talk today is a strong believer in health systems, and so I won't need to do much to convince you that strong and resilient health systems are really important to prevent and respond to infectious disease outbreaks. We've probably known this for a long time, and this almost goes without saying. However, I think what's been less well appreciated is the fact that health systems themselves can also be very adversely affected by outbreaks, and this is something that we really learned a lesson in West Africa when in 2005, 2016, primarily when there was a big outbreak of Ebola in a number of countries in West Africa. And we saw, for example, there were huge declines, very large and widespread declines in use of total health services. For example, a systematic review has suggested anywhere up to 18% of total health service utilization declined during the outbreak. And not only that, we saw really devastating effects across the health system. For example, in those same countries, between 1% to 8% of all human resources, so all health workers in those countries, actually perished as a result of the outbreak. So it's clear that health systems themselves really need to be protected and to be considered as potential things that outbreaks can affect as well. And while West Africa really put us on a track to start thinking through what I think resilience means and how to build these new strengthened health systems, I don't think we were able to put into place a lot of the lessons from West Africa. And I also think that much of the efforts that have been done have largely been within the public sector. And there's been little consideration of what's happening to the private sector during these outbreaks. And so what we're going to talk about today is basically the manifestations of that. We know that the private sector plays a very important role in health systems around the world, in particular in low and middle income countries. It's pretty widely accepted that governments play a very important role in terms of, for example, fixing forms of market failure, whether they be the provision of public goods or addressing information asymmetries within healthcare systems. And so governments do have a very important, and I would say even primary role in terms of steering and to a large extent financing healthcare systems. But yet on the provision side, we see that the private sector plays an enormously important role, right? So we see in particular in low and middle income countries, the private sector playing a very important role, not necessarily the major role, but it does depend on the context. Some countries like India, that might actually be true. But otherwise, we see them playing important roles in even primary health type services. But increasingly, what we're seeing around the world is also an increased specialization of private hospitals in many of these settings, where we see the proliferation of high-end tertiary care or diagnostic services that are being delivered by the private sector. And that's sort of the context to what we knew what was true before the pandemic hit. Starting in the spring and into the summer, our own observations seeing there was a lot of news coming out about things happening, particularly at the sort of public-private interface within healthcare systems, some things that were quite unsettling. We decided to do a search, a bit more systematic search, to try to understand exactly what we could learn from looking across the world to see what was happening within the private sector. And so we used a database called GDELT, and I can go into that afterwards if people have questions, but it's a big data approach to aggregating global media sources for terms that were related to COVID and private health. Based on that, we identified a number of articles. We manually inspected those to see if we could find some content related to private health sector, and in fact we did. Almost 1,000 articles were identified. And then using those articles, we sort of try to organize them around common themes, common patterns, in order to see, what can we learn from what was happening. And based on that, we came up with this kind of idea of a triple crisis. So there are sort of three manifestations, three common things that we saw in many different contexts. And so as a result, we think that these are kind of general patterns that we can generalize to many different settings. And so I'll just walk you through, and again, I'm going to be largely descriptive and sort of saying what we saw and what we think happened, and then Owain will tell you more about sort of the background and the whys. But these common patterns, as I said, really are global, and we'll focus in on some examples from middle-income countries and low-income countries. So remember that big drop in health services I mentioned in the context of Ebola? Well, surprise, surprise, it happened again here in the pandemic, where we saw very dramatic declines in the use of health services for a variety of reasons. Some of this is because of fear that you would be infected, so people deciding to not come in for services that they would otherwise. Many governments or providers actually decided to postpone elective and non-essential health services. Many places there were drops in medical tourism. If you're the public sector and this happens to you, in particular when you're trying to fight a pandemic, that may not be so bad in that it allows you to free up a little bit of capacity to treat other patients. But if you're the private sector and you're 100% revenue driven, this can be a really important shock to your bottom line. And so what we saw was, pretty severe liquidity and financial crisis affecting many private providers. Not only that, there was also increased costs associated with delivering care in the context of a pandemic, whether being, having to purchase more PPE or having to test patients before they can come in and get services, and also ensuring that your health workers are safe and protected. Many healthcare providers, for example, would set up special living accommodation for their health workers. And then more broadly, because this was actually also a big economic shock to many countries, we were starting to see the delays in payments to providers, either through state-funded health insurance schemes, or in particular countries where people get their health insurance through their jobs. We were seeing a lot of people actually losing their jobs and therefore losing their health insurance coverage. So just give you some examples, here are some of the headlines we saw, anywhere from Jordan, the United States, Nigeria. I threw the United States in, even though it's not a low and middle income country, but it's kind of fun to throw that one in, and other places around the world as well. And so as a result of that first crisis, what we saw then was the manifestation of a second crisis, which we'll call the service provision and pricing crisis. And so because of this shortage of revenues, what we started to see were many private providers in many different settings starting to increase the costs associated, in particular, with treating COVID patients. And in some places, asking upwards of $1,000 a day to treat COVID patients. Also seeing them requiring upfront payment for treatments. In places in India, we saw upwards of $1,000 to $2,000 upfront in order to even walk through the door. Saw some example of in Zimbabwe charging over $5,000 just to have people come in through the door. And then, of course, adding in all kinds of bundled payments associated with, PPE testing to go along with the treatments people are getting. Also, we see a lot of either sort of refusing to treat patients who couldn't pay, or also sort of governments also simultaneously kind of saying that private providers couldn't provide these types of services because of the lack of regulation or the lack of uncertainty about whether they would be able to provide quality care. And then, of course, there was the health worker concern that we saw again from previously. There was a lot of examples where healthcare workers were getting infected. And then, unsurprisingly, many health workers deciding to walk off the job or go on strike in order to demand better protection from their employers. So again, lots of examples from around the world: Manila, South Africa, Bangladesh, all kinds of different examples here of this sort of reaction by the healthcare providers to their liquidity situation. And then finally, because of that, and I think largely as a result of that sort of behavior that we observed in many settings, what we start to see then is the way in which the government responds back. And so we see, for example, examples where the governments put in price caps or other types of regulations to heavily limit what private providers could do in the context of the pandemic. As a result, we also see many healthcare providers kind of coming back and, for example, refusing to treat patients unless they could get higher rates. And so this kind of negotiations that were happening in many different settings were being talked about in the news. We actually saw to the point where governments started providing bailout packages to private providers. This is not the time to lose 30 to 40% of your providers. And so we actually see governments providing packages to keep some of these providers afloat and solvent. We actually even went so far to see places where governments actually stepped in and either nationalized or sequestrated certain types of private assets in order to provide services during the pandemic. So we saw this in Egypt. We also saw discussions of nationalization in places like Nepal and Mexico, which didn't actually happen. And then a third point, which I think came up throughout, lots of examples of where there were accusations on both sides of one side or the other withholding information about what was really happening in the pandemic. So I think that's just to give you a sense of what we found. As I said, I'm gonna pass it over to Owain to talk a little bit more about the whys. But just a couple of thoughts on this. What is clear in reading some of these things is that there was, at the least at the beginning, a lack of integration of the private system, and it's not COVID-10, it should be 19, into the system. So for example, the national health system largely excludes private providers. So there was a lot of upfront discussion about not even knowing what types of resources were available in the private sector. Lots of examples of lack of trust between providers. There's lots of, the stories were quite vicious, one side accusing the other. So a lot of sense of mistrust in those different contexts. But also starting to see a lot of discussion about what should the system look like and what could the system look like in a post-COVID world. And so lots of discussion starting to happen in terms of thinking through what's next. And so I'll stop there and I'll hand it over to Owain to take over.
Okay. Hi. So just as a bit of background about myself, I've both worked in public health at the University of Queensland School of Public Health, where I taught health systems for quite a while. But I'm also a political scientist and a political economist by training. So whereas Karen has outlined our paper in Global Public Health, which kind of focuses on the triple crisis, I want to talk about the background politics and drivers of this, and then come up with some sort of broader political economic recommendations or things to pitch to you as an audience about what we should learn from all of this, and what this means for the future of health systems in an era where we should be going both towards better pandemic preparedness, but also building towards UHC and UHC and health security. So it's a kind of the background politics, but also looking to the future of health systems. So I'm at the University of Leeds, and as Karen outlined, these market failures have been widespread, and there's a broader sense of market failure at play here. It's also about how the COVID pandemic has exposed some of the key redistributive failings that have been embedded in health systems. And I want to concentrate here on some of the background governance drivers of the failures that Karen outlined, both at the national level and the multilateral level in particularly. Now, I think the key here is we're on the back of 20 years in global health, but particularly with regards to health systems, where we've lived in an era of the public-private partnership model, and that's been seen increasingly as pivotal in progress to UHC. But also, this model has been cruelly exposed by COVID. The private sector has proven extremely fragile in terms of providing health security. And it's also re-exposed, I suppose, how fragile the private sector is in terms of providing quotidian, normal, everyday public coverage in terms of the normal health requirements of populations, particularly those less well off. So it's a kind of exposure moment. It's a revelatory moment in that sense. And what we see in neoliberal multilateralism in the last 4 decades, but more acutely in the last 2, is the stress on the public-private partnership model. And I've argued in the development piece, and it's also in mine and Karen's piece, that this is a very thin veil for what has actually gone on. We've seen, particularly in the tertiary sector, at least since the global financial crisis, an increasing financialization of tertiary care in low and middle income countries. But we've also seen it in Europe and the United States and even Canada in areas such as disabled care, aged care, and tertiary care. So there's a process of financialization and neoliberalization of health systems. We've also seen at the same time, kind of at the multilateral level, increased stress on financing and social risk protection via insurance as the route to UHC. And there's been far less of a focus, including in the World Health Organization, on the who provides health, whether that being the provision of health by public services and public systems has kind of become recessive in the global political economy of health systems. We've also seen the World Bank particularly active in the process of financialization and in seeding and consortium building with regards to the entry of hyper financialized capital, hedge funds, investor groups into tertiary care. India is a very good example of this, but by no means not the sole example. And also, we've seen the ongoing activities of the IMF, most recently high profile in 2019 for example, in Ecuador and also in Pakistan, with loans with conditionalities with regard to increased privatization of health services and systems. And in Ecuador, the dismantling of their pandemic response team. And I then want to focus on, at the end, look at what's happening in COVID and post-COVID with regards to the multilateral governance of health systems. And I don't think it's a good story at present. Spoiler alert. Of course, the market failures that Karen pointed to in her discussion have been long in the making. They're a product of austerity and cuts to the public services and public sector, and including public health systems. They're a product of financialization, which I just meant, but also the retreat of the state from health systems and public health. And we see a process of rolling back of the state and the rollout of neoliberal marketized health systems. And within that, we see new modalities of rolling out the market, and financialization is one, but by no means the only example of how the market has been rolled out. But it's not just a story of multilateral governance failure. It's also a story of permissive states. States are being complicit in the process of market entry, and that process has been accompanied by very poor regulation of the private sector. It's poorly assimilated into many national health systems. The process has been laissez-faire, and Karen alluded also to the huge informational black holes that exist in many LMIC systems with regard to basic private sector capacities, numbers of beds, service orientations, number of staff, so on and so forth. There are huge informational black holes. And really also a story in many LMICs of a complete neglect of the public sector and poor levels of health spending. And these capacities in the public system are being, again, cruelly exposed. States have lacked regulatory and legal capacity with regards to the private sector. They've lacked informational capacity, and many of the responses to the COVID pandemic and to the triple crisis that Karen and my paper pointed to have seen states just formulating very chaotic ad hoc responses in an attempt to gain, in many cases, gain access to private sector capacities as part of national pandemic responses. So in sum, I think at the state level, these hollowed out capacities have been exposed, but also the complete or majority dependency on private sector capacities, particularly in the tertiary sector. Regulatory oversight has proven weak, and regulatory responses have been chaotic. Capping, negotiation, legal sanction, threat of nationalization have all been apparent across LMICs in all regions. And we've also seen huge levels of workforce and public discontent with the status quo. We've seen the abandonment of the health workforce in many countries in terms of PPE and basic safety measures. But we've also seen the exclusion of the public from treatment and the gouging of patients in terms of price. It is not a happy story. But at the multilateral level, this has gained, the piece I wrote in development has gained a bit of criticism, but also some support. I mean, who during the pandemic, the World Health Organization has largely ignored and evaded the crisis in the private sector. It's provided no real direction or leadership in terms of how to respond to the crisis of private health. I've tracked and looked at what they've done, and it's not a particularly good story, and it's a very partial governance response, and that's a benign reading of it. And the private sector COVID-19 initiative, which I believe Madhu is part of, you know, it's focused on a couple of countries harnessing the private sector, so on and so forth. But it's very marginal, and it's out, to my mind, is the real governance failure of the World Health Organization during the crisis, rather than anything abstract or to do with health security. It's health security, really. That's in many ways for me a background story to this. And we have to historically understand WHO's own retreat from the public in national health systems. I think there's been a détente with the Bretton Woods institutions and the IFIs with regards to the role of the market and treating the market as an integral part of health systems. A case of there is no alternative in some respects, but there has been a withdrawal, especially if you look at documents such as the 2008 World Health Report, you know, written by Wim de Clercq, which was very strong in terms of demanding a retreat from the markets in health. And the World Bank and IFC, in terms of their COVID crisis response, have really doubling down in terms of the past. We see, to my mind, especially from the IMF, a quite aggressive return to the structural adjustment programs of the past, repayments with conditionalities, short-term repayment schedules, and a demand for further privatization and market access into health systems as part of a lot of their national lending to date. And we see really, in terms of the IFIs, a path dependency in terms of austerity, liberalization, and market facilitation, all towards further state rollback in terms of the public health. In terms of what I talked about in terms of my recommendations, I won't badge these with Karen. I mean, Karen would be a lot more nuanced than me, and we joke about it quite a lot. But you know, this has left the private sector in health with very little in terms of credibility, in terms of its manifest market failures in the COVID crisis. And it really doesn't bode well in terms of their viability in terms of future public health events and health security. I think with regards to UHC and health security, states clearly, all states, HICS and LMICs need to spend more on health, and the private sector should be rolled back from health systems. It's gone too far. And I think there is an opportunity in the WHO's Health Systems for Health Security framework, which it's bringing to the World Health Assembly, the next World Health Assembly, which it looks as if it's going to be demanding greater public and state role within strengthening health systems for future health security. And I think there's also an opportunity in terms of state bailouts of private sector providers during the crisis, in terms of leverage, in terms of better regulation of their role. I think there's a clear need as well for better monitoring of international financial institution loans and conditionalities during the crisis and after. Debt is rising, and unless we want to avoid the mistakes of the past in terms of the private and health, then we really need to pay attention what's coming out of the International Monetary Fund and the World Bank group. Okay, I'll leave it there. Thank you very much.
Thank you, Karen. Thank you, Williams, for this very nice presentation. Now I open the floor for questions. I have one question from Oriol. So, do you see the way forward in the direction of post-WWII in high-income countries? Or was it a process historically not replicable again? Who will take this question?
I'm sorry, I'm a bit lost with WWII.
So World War II.
World War II.
Oh, yeah, right. Okay.
Looks different. I mean, I can start us off at maybe a little bit. You know, I think, you know, what did the world look like before World War II in high-income countries? I mean, there was, you know, not a lot of social health insurance, national health systems. They were not particularly common at the time. And, you know, some people have argued, and there's other theories out there as well, but, you know, that World War II was one of the big impetus for the formation, for the sort of acceleration of the nationalization of health systems in many parts of the world, you know, definitely in the United Kingdom, for example, but elsewhere as well. And so, you know, I think we should, you know, this is what we've been sort of saying too, is this is a really important moment to think through what we want health systems to look like post-COVID. It is possible that it is this type of event that is the useful trigger for these types of conversations and could actually lead to a lot of reforms. We do actually start to see a lot of countries, we've seen it in the news, of countries starting to talk in this way. We really need to fix this. We need to do something. But it does mean that there needs to be policy space for this to happen, and that the environment is such that it can allow it to happen.
Yeah, I'll keep my comments quick. I mean, this is the first major, in terms of the global political economy, this is like World War II in many senses, in the sense it's a genuine structural crisis, global structural crisis. And it's unlike cyclical crisis that we've had in, post-financial crisis of the past. But neoliberalism for me is it's emerged from every crisis it's been through in terms of health and society and the economy. It's emerged from every crisis reinvigorated and slightly changed, but nonetheless still present. And I think this opportunity at the moment that Karen spoke to is a liminal one, in the sense that it could go either way. I'm very worried about how debt is going to be used for leverage for health sector reform, further health sector reform. But there is also, in counterpoint to that, deep discontent with the way that the private sector has functioned, both from the health workforce, which I think is vital in this story, but also from populations. So it could go either way. I'd like to think that it will lead to progress, but previous crises of neoliberalism haven't pointed in that direction, sadly.
Thank you. Owain, we have a couple of questions directed to you, and 3 of them are similar. So William Wells asks, what do you mean by financialization, and why it can't be assumed to be bad? And the follow-up question is, the private sector should be rolled back from health. That's the statement that you made. And what does this mean in practice? And the private sector delivers the majority of the care in the LMICs. So how can we ignore this reality?
Okay. So financialization basically refers to a one-step removed process whereby any sector, including health, is the subject of investment, usually from investment groups, hedge funds, financiers, international capital flows. So you've seen that in the health sector, for example, in India, has been the subject to, the tertiary sector has been subject to a number of buyouts and investments from Singaporean-based investment groups, Dubai-based investment groups. We've seen the same in aged care across the world with investments from groups such as Blackstone Capital, so on and so forth. The problem is with that, it's mobile capital, and it's often not grounded in the country where they're investing. So that's got regulatory and accountability problems. So it's a kind of process of investment. Is it a good thing? No, I don't think it is in health. It's often by investment groups with no contact or experience with providing healthcare. It's an investment opportunity. Medical tourism in many LMICs has been one of the great motivations. The expanding medical tourism industry has been one of the great motivations for the entrance of international investment capital. In terms of the private sector, I mean, clearly removing or rolling back the private in health is not a short-term project. It's a medium to long-term project. I don't think we can accept what it means in terms of access to health services. I don't think the insurance schemes and settlements to date have provided universal coverage, and I don't think they ever will provide it. I think the private sector has proven itself to be fragile and exclusionary. And the question is do we want this to persist? My answer to that is not. And that's a political choice, and one that we can exercise politically as people. and we make a decision and we provide alternatives. And that's perfectly feasible to do. Many LMICs today are putting missions to Mars and to the moon. And yet the public provision of health is somehow obscenely, somehow we can't deliver that. Of course we can, and we should.
Okay, there are similar questions from the audience. It's the same thing that the says that picture is not that bleak everywhere, though the private sector has been functioning. So I echo your statement that there are alternatives, and I see one of the alternatives is to leverage the private sector resources. So at least from the LMICs, I can speak that the private sector, especially in the mixed health system, private sector has been playing a major role. So what is the alternatives that you think of?
Karen, do you want to, or you?
Yeah, I mean, I think, what we're seeing, what we see most obvious when we see the private sector is we see private providers. And, what we don't always see is who pays for them. So Owain and I, just so you know, we don't agree on everything. So just to be clear, and this is actually part of the fun of working with Owain, because we don't agree on everything. But I'm a little bit more agnostic in terms of whether I think private providers are good or bad. I think what we've seen in this particular context is some manifestations of some pretty negative behaviors that I'm quite concerned about. But it's also my belief that every system behaves exactly like the way we set it up to perform. And so in the sense of, what we're seeing was based on probably some more underlying failures. And my personal belief is a lot of that comes down to who actually pays for services. So it's actually quite possible that we could continue to have high levels of private provision in many contexts. But I think what's important to overcome some of these market failures that we've observed is that there are assurances at the financing side, so who's paying for these services, that can play a big difference. One thing we would like to dig into in another later on is really, did some places actually do better than others? The way that we search the media and so on, obviously you get the negative news, you don't necessarily get the positive news. But there likely are some important examples too of places where the private sector did behave in different ways, and perhaps that might be explained by differences in, for example, how they are paid for. There's a lot of countries, Canada, where I'm from, Madhu's from, we have almost exclusively entirely private providers, but they're almost exclusively entirely paid for by public payers. So it does mean that you don't always get the same outcomes. And so what we've seen is perfectly what we would have predicted based on how we set the system up. And so I think there are ways of working within the system to tweak it in such a way that we can work with what's there and perhaps try to overcome these types of challenges in the future.
Yeah, I would just say as well, this isn't failure. I mean, we've looked at LMICs in this study. I mean, the United States system has really come very badly out of this. A lot of rural hospitals have closed. The furlough of health workforce was enormous. By April, there'd been 1.4 million health sector workers had been laid off in the United States. In Europe, one of the stories that hasn't got out there is the fact that private providers were essentially bailed out. The same is true in Australia, and there were thrown also similar lifeboats in Ireland and the UK. So, it's not just a LMIC failure. This is kind of mass failure. Of course, responding to the person who said there has been good stories, but Asian countries, the private sectors performed pretty well. But again, it required state intervention. It required price capping. in a number of Asian countries very early on. So, you know, the state had to step in, which is the role of a regulatory state. That's what leadership and governance is all about. But the fact that those failures were so embedded and the private sector was so fragile, I think for me, you know, me and Karen, as she said, we do disagree, and that's good. It points to a dramatic recalibration of the relationship between the public and the private with regards to health systems. That's long overdue. It predates COVID.
Okay. So we do hear from the audience a couple of examples where the governance has really worked well, and the private sector, there's a great involvement. However, there are a few questions that private sector in LMICs is vast. It includes the nurses, the doctors, the drugstores, small and large labs, and so on and so forth. So the question is, should we continue pushing for well-defined PPPs that will demonstrate the viability and value? Is this one of the options that you think of?
I mean, I'll step in here. I mean, I think it really depends on the context, right? And I think it also really depends on what the current setting is and what is currently available. You know, I'm definitely in the camp of it's unlikely that we will ever, no health system really is all public or all private, and so there will always need to be some interaction between these different groups. And so it's inevitable that there will need to be more dialogue, more interaction between public and private. I do think the government should continue to play a more dominant role in these negotiations. And I think, especially what we've seen in terms of some of the backlash, some of the negative consequences, that there is an opportunity or a need at this point to really think through what types of regulations go into these types of settings, so that in future that we can try to mitigate the potential negative consequences that come from having unregulated and regulated providers.
I'd agree with Karen. I think one of the things it has exposed in all but a few best case examples in LMICs is how ad hoc the legal and regulatory response to the crisis has been, both at the state level and, you know, in countries like India at the substate level below the union government. It's been, you know, it's been highly uneven, is putting it kindly, and, you know, exposes how fragile the regulatory oversight of the private sector is in a lot of countries. And India is by no means exceptional in that story. It's happened in Brazil. It's happened in a number of countries. And I think that need to toughen up regulation and assimilation of the private sector international planning and responses is desperately needed for health security.
Madhu, you had something to say? I saw your hands up.
Yeah. So there is just no question at all that there's been catastrophic market failures during this crisis, and private sector, I think, is merely healthcare is merely one among them. Look at the market failure right now around vaccine access, right? Vaccine equity. There is not even a hint of equity in how vaccines are being rolled out. And us relying on pharma companies that have already received massive amounts of public money, and we still can't get them to be accountable on the pricing, is just absolutely mind-boggling. This would have been the time for governments to have started manufacturing vaccines and made them available free for the entire population, but no government is showing any spine in terms of making these drug companies accountable for the outrageous vaccine situation. So I think the question now is, as we all agree, no country is pure public or private. It's all mixed in some form or fashion, not just in health, in every aspect of our life. We resort to private services when we fly on airplanes, right? So I think it's important to ask the question, is it more a regulatory governance failure, or is it a genuinely impossible situation? In other words, are there good examples where countries have genuinely done well that we can learn from and use as we rebuild from this crisis? There's no question that governance has to be better, especially in countries like India. Just allowing the private sector to run wild is simply not a viable solution for Indians. And I think Indians all appreciate it now. After the crisis, they've seen how terrible the situation can be. So I think it will be good to talk about what policies have worked in which settings that we can potentially learn and leverage in other settings. What learnings can come out of this crisis, I think, is an important issue to discuss.
I think that's a really good point. And I'll just keep my comments brief because Karen's much more of a health economist than I am. I'm more of a political economist. But I think about what Madhu just said. I mean, there are some areas of life, of global life and social life, that the market doesn't belong in because it just doesn't work. Vaccines is a good case in point, as is medicines. I mean, we all know about neglected diseases. We all know why there's been no serious investment into coronavirus vaccines other than by organizations such as CEPI. It's because the people that they were seen as affecting were too poor to constitute effective economic demand. So the innovator firms simply didn't invest in R&D. And you can add to that story TB medicines, you can add, the list goes on. And you have to ask yourself the question, if the market can't function, what do we do about it? And so far, our response in terms of vaccines, but also in terms of healthcare, is to, kind of try these public-private models, circumventing the market via agencies such as CEPI or Gavi, Global Fund. But it's all patchwork, it's all Band-Aid. What we need to do is take it seriously and take certain areas of health out of the market because they don't belong there.
Yeah.
I think public health is distinct from delivery of medical care. I think the private sector does play a critical role in delivery of medical care, and if it is regulated properly, it will deliver. But public health, vaccines, water supply, anything that is true public health, private sector doesn't care, doesn't belong, will not do a good job. I just want to separate the two because we tend to conflate them, right? And I think that's where I think if done correctly, the medical care part, if reimbursed correctly, structures are in place, if accreditation and other principles are in place, I think it's not just hypothetical, it's already happening in many countries. Whether it's happening enough at scale or not, or could we do better or not, I think is a worthwhile point for debate.
I think it's a big debate. I'll turn over to Karen here. I can see she's champing at the bit. I mean, it would be a very interesting debate to have, and I'm maybe being deliberately provocative in this talk, which, is kind of entertaining for everybody, hopefully, and not too annoying. But, what is the claim for the private sector in delivering health? Is it somehow more efficient? Is it better at doing it? Or because it certainly excludes proportions of population because of price, unless there's social insurance in place, social risk protection that provides for that health. But there's so many countries where that simply fails. So we've got to do better at that, at least. But what we have is partial health systems for partial populations.
Perhaps an analysis of the same nature that you've done, maybe backed with more actual data collection in settings where regulation is in functioning versus it's not, might help us nuance this argument rather than a blanket statement that private sector doesn't work. Right? I think that would be, I think, very helpful.
Yeah.
I think we have the same follow-up questions from one of our audience. So our friend from Zambia states that the governance from the government was so good and the private sector engagement was very optimal. And another one asked from the Kenya that, if it would have been better if you had looked at both the countries, if a private sector has done well with the regulations intact, and compare with other countries where even though there were regulations, but then private sector did not do well. Did you look at these two scenarios?
We did not. Again, wasn't a stated goal, and I want to be clear too. And I'm still very agnostic about the private sector. I think it has a role to play in certain settings and not in others. Definitely not out here saying private sector is bad. What we did observe, based on news media, were these manifestations, and it's clear the news is likely to be much more biased and to tell you when things didn't work than when they did. So it is definitely one of our weaknesses of this approach that needs to be taken and caveated. But at the same time, I think it's more than just regulation that I think varies between these different contexts, and so it's even difficult to know what regulation is and to monitor it and so on. But I definitely agree with all the comments that it would be really interesting to do more of an analysis of understanding where private sector has done well or not. I know WHO, for example, I've seen some case studies that have looked into this, but there's almost 200 countries in the world, and my guess is on average we saw more of this negative than the positive, in particular in these countries where we didn't shape. I mean, English language to some extent may have shaped the countries. It was really these kind of middle income countries where we saw it, and that I think is really consistent with the story of where there is an active private sector but not enough regulation to control it. So we can't say that that's causal. But I definitely think that is sort of what we would expect to have seen in those particular countries. I'm actually not as surprised as we have more positive stories coming out from lower income countries. There we have less aggressive, less dominant private sectors. So it may not have been much of a problem, but it's clear that we need to better understand where things worked well and where things didn't work as well.
Yeah, I think this is clearly, there's a lot of nuance missing from both studies just because they are first cut studies. And Karen is completely right in the way she described it, the limitations of the study. And I think people are also right that, we need, this is just the start of a kind of research project that should happen. Is we need to look at what happened in best case examples and compare them with worst case examples. Yeah.
Okay. So I have a question. In India, especially, government looked at this as an opportunity to diversify some of the systemic issues like supply chains, for example, personal protective equipment, manufacturing, medical masks, gloves, and etc. As far as the medical care is concerned, the private sector did not rise to the occasion. And we see a sort of skepticism towards public-private partnership in the healthcare. So in your review, did you see this kind of, since the private sector was not rising to the occasion, how did the government actually started looking at the private sector using the lens of public-private partnership?
Well, I mean, I think we have mentioned, a regulatory response was required, no matter how ad hoc it was, and that there's a kind of spectrum. There was a spectrum at play from negotiation in terms of access to surge capacity and pricing of services, through to threat of legal sanction, sequestration of beds and hospitals, through to threat of nationalization. So there's a broad spectrum of responses at play. I mean, but it's clear that in a lot of country examples, whatever the nuances and particulars of the way the public-private partnerships have been handled and the institutional composition of those partnerships, is that that model has come under some stress in this crisis, and that relations between firms in countries as diverse as South Africa, Peru, India, have become very stressed and fractured. Now, I'm not saying that relationship in PPP is collapsing or anything like that, but it has come under severe strain. And I think that's extremely interesting. I certainly think a lot of countries won't go back to a system of loose regulation and oversight of the private sector. I think maybe that is one lesson that has been learned, hopefully.
Okay. So there is one last question. I think we can take this. It sounds like Owain answered his own question in the sense that the system to work, there needs to be a social insurance in place. In LMICs, they can't cover all. But isn't it the WHO goal in putting this concept in UHC? It's very well there in the WHO agenda.
I was gonna say earlier, when people were talking about vaccines and these other things, that we said that there's really no role for private actors in, right? These are these pure public goods, and so therefore government should have a really important role in providing them. I think of UHC as a public good too, right? It's a very aspirational kind of concept that everyone has, to the extent is possible, some form of coverage, some form of protection. And I think every country can do that. It may not be exactly social health insurance for all, but I think every country can make steps towards ensuring basic provision of some level of service and some level of care when needed. And so, I think it is exactly what your question is about, right? UHC is something that is essential for every country and must be a very strong role for government in providing.
Sure.
Yeah.
So, is there anything that you would like to add, Owain, and then we can wrap up the session?
No, I think Karen answered it very well. My problem with social risk protection in a lot of LMICs is it manifestly still doesn't cover everybody, and that's problematic.
Okay. So we have one last question, Petra. Can we take that?
Go ahead.
Yeah. So we have a question from Mark from the Western perspective, though. He says there is a temptation to blame proximate actors, example, IFIs, the world wars. But there's a stronger argument in my view that domestic stakeholders have driven the development of the commercial private sector, largely through a failure to invest in the public sector. The World Bank, IFC, IMF have not had much to do with the private sector growth vis-a-vis public sector, except the margin. So would not the argument that we should drive the process of rolling back the private sector be, well, a somewhat neo-colonial approach?
Well, I mean, Mark, hi. I disagree with you actually completely. I think what we've seen in very uneven process is, well, I don't completely disagree with you. I agree with you in half of it. I think, yes, I think state elites and leaders in a lot of countries have embraced the private sector. I think a lot of governments don't want to pay for health, and they don't want that to come out of public finances where they are available, and they're happy to wash their hands of health service provision or to minimize their role in it. That's where I agree with you. And you can see that in extraordinarily low rates of GDP spending on health throughout LMICs. Where I disagree with you is I think that the IFIs historically have been very active in promoting privatization, but particularly in promoting austerity and the rollback of the state. And that opens a window for the rollout of the market. And time after time, that's proven the case. And it seems to be the case in a lot of the loans and conditionalities emerging from the IMF and the World Bank at present. It's kind of business as usual and a return to form. So yes and no from me on that.
Karen, would you like to say some closing words?
No, I mean, I think I won't wade into that one, but I think this has been a really interesting discussion, and I was just scanning actually the Q&As, and unfortunately we didn't get to all of them, but I've been told that we'll get a copy of them. So I'm really looking forward to reading those, and hopefully we'll have a chance to engage more on this topic with you in the future.
Yeah, if the emails are there, I'm happy to write as well to any of the questions. That I'd welcome any interaction with people on this.
I think you've both given us a lot of thought and some excellent provocative ideas. And yes, as you see, there are some rich questions that we didn't get to. I think we could add on another hour. Sri, thank you so much for moderating. It's excellent.
Yeah.
What we will indeed do, we will pull all the questions together and send them to the authors and make that in a final discussion document that we will share with the audience. And if you do have any other questions, you can always reach us at the TBPPM Learning Network, and we'll make sure that we continue. We're looking forward, obviously, to see the next stage of your work, where we see more of the good examples that countries could potentially follow, like where to guide on regulations, or where are good examples of policies that have worked, or collaborations of public-private mixed solutions. So I think that's a piece which our audience, particularly working in practice on TB control and engaging public-private providers together, is a piece of super helpful guidance. So I thank you both as speakers for lovely, strong, provocative findings, and actually bringing the discussion forward that we all need to have to take better action on the ground on healthcare. Sri, thank you very much for moderating. I'm going to launch a little poll for our audience to get some feedback on the webinar. Please have your thoughts, and I would like to let the audience also know, thank you for your active participation. It's been really great to see your questions. We have a new webinar coming up on the 9th of March, where we'll be looking at private laboratories. We will be sending out a lot of the information. This recording will be available on YouTube. We will be pulling the whole recording, plus a report, plus the Q&A, and make it available on our Learning Network website. And with that, I think we can close for today. Thanks again, speakers, audience, Sri, and all panelists. Really appreciate it, and have a lovely rest of the day. And see you next time.
Thank you for engaging and the questions. Much appreciated. And thanks, Madhu and Sri, for